2 excitement, okay, stage 2 will be delirium, so stage 3 will come into the plane of surgical anesthesia. In plane of surgical anesthesia, again stage 3, plane 3, so there are again planes depending upon losing of each reflexes. Okay, so it will start with eyelash, corneal, all these reflexes will be involved, and stage 3, plane 3 will be the patient will be in a plane of surgical anesthesia, which is ideal. Okay, if it progresses to the next stage, the patient will get respiratory depression, a lot of complications will happen. Okay, so we are maintaining at stage 3, plane 3. So these things you have to, for your exam purpose also, you can remember all this. Now, this is our mannequin. So how you position the patient, depending upon each intubation, positions will slightly vary. But most of all, you're going for an oropharyngeal intubation, oh sorry, orotracheal intubation. So how you position the patient is a sniffing position, 15 degree. Okay, you have to head tilt. Okay. So after that, what you have to do is you have to take your laryngoscope. So there are different types of laryngoscopes. Okay, usually this is you can remove it and keep it back. Okay, and this is there are mainly two types. One is the Miller's and the second one is a Macintosh. So this is what? This is the Macintosh laryngoscope. Why Macintosh? Because it is curved. Okay, Miller's will be straight, and these will have different sizes. So the usual normal size we take for an adult. Okay, so how you assess is it? You have to first you have to, so this usually will have a light also, so you can visualize properly the vocal cords. So now you position the patient at 15 degree. Okay, there is a chin tilt. Okay, you have to lift the chin down. Okay, downwards. Okay, downwards, and probably the mandible also downwards. And then what you have to, so this is the position actually. You have to incline it nicely, and then you have to position the laryngoscope inside. Okay, can you see this? Can you come this side? So once I position it, with the Macintosh, what I can do is I can actually tongue. Can you see here inside? If there is a light, it will be better. So I have to shift the tongue to one side. Okay, and I have to visualize the epiglottis, and I have to see the vocal cords. Can you see here? I'm not very sure, but I have retracted here. Can you see there? This the first one. So the opening, can you see there? So then once I find it, so I have to choose an ideal size. Usually for an adult, what is the size? Correct, only 7. 7 to 8. Okay. So usually I'll take a 7 number, this one, and I have to place it inside. Okay. So once I place it inside, I have to inflate it with about 15 ml. Here I have to inflate it. Okay. So I have to inflate it with 15 ml of air. Okay. Once I get the resistance. Okay. So that is how I go ahead with the orotracheal intubation. Mesotracheal, same thing. Only one thing you have to be careful is you have to put a little bit of local anesthesia gel or something in the nostril, so that there will be a little bit of, it won't be that painful. So what you have to do is initially induction will be given. Induction will be either gas, okay, any inhalation agents, or you can put a IV. So once you start inducing, then there are certain things called propofol, which is used for induction and maintenance. So you can continue the maintenance with the same, or nitrous oxide is there. So you can continue desflurane, sevoflurane, all this can be used. These are gases. These are used for maintenance. Meanwhile, initially only you will be giving a skeletal muscle relaxant also. Okay, so then all muscles will be relaxed in the position. So it's basically, general anesthesia is a combination of many drugs together. So you might give an anticholinergic in the same place. Okay, so and then an antiemetic would have been given. Okay, so and then induction agents would have been given. Okay, so all these drugs together would have been given.